we're able to capture accurately the inputs that we hear today. So appreciate your understanding of that. Good to go. All righty. Thank you. Real quickly, what to expect today. I probably won't read all of this that's on the screen. Excuse me. But we are going to cover the Rules Advisory Committee member fact sheet that I sent out to everyone who registered for today's session. We will talk about the Oregon Administrative Rules, the 3 specific rules that are drafted. And just to remind the audience that administrative rules have the effect of law. What administrative rules do is really set the framework for how the agency, the Oregon Health Authority, really operates and complies with both state and federal regulations. And in particular, the rules we're talking about describe how we operate components of the Medicaid program and the benefits. Oregon's Medicaid program is called the Oregon Health Plan, or we often will abbreviate that as OHP. With these Rules Advisory Committee meetings, the purpose of this is really to hear from the communities that are affected by administrative rules and listen to your suggestions to draft or propose rule language so that the language is clear and represents what communities need. We will also talk about the racial equity impact of these administrative rules and ask for some input on the potential fiscal impact of these draft rules. Okay, next slide. Then we will dig in to the details about the 3 draft rules that speak to the care coordination that is in Division 120 of Chapter 410. You don't need to memorize all these numbers, but it just is how the Secretary of State's office organizes administrative rules, and all of the rules within Chapter 410 relate to the medical assistance programs, so the Oregon Health Plan. Division 120 rules are broad overarching rules and that specifically also address how we operate programs for what we call fee for service or open card. You might hear those 2 terms used interchangeably. And as I mentioned, we'll talk about both racial equity impact and fiscal impact. And then finally, we'll close out with what are the next steps in the rulemaking process. I know a number of folks on today's call have registered to listen only or observe today's Rules Advisory Committee, and we're so happy that so many of you are here. I believe there were a total of 69 people who registered for today's session, which is outstanding, and I see that there are about 48 people in the room, so very happy about that. We also have individuals who expressed interest in being a RAC member. And so I will ask Spencer to do a roll call of those individuals. So we make sure that we can capture the RAC members who are able to join us today. So Spencer, I'll let you take it.
Thanks so much, Diane. We will start with Veronica Espinosa. Are you with us today, Veronica? Alicia Silney. We'll just ask you to unmute and say here if you hear your name called. Lori Jones. Lori Brock Stewart. Hazel Clements.
Here. Hi, this is Hazel. I'm here.
Thank you, Hazel. Tammy Stump. Kimberly Tice.
Here.
Thank you, Kimberly. Molly McGrew. Marilyn Bernardelli.
Here.
Thank you, Marilyn. Julia Bryson. Adam Peterson. Thank you, Tammy. I saw your chat. Sarah Holloway.
I'm here.
Thank you, Sarah. Carissa Smith.
I'm here.
Thank you, Carissa. Glenda Fossum Smith.
I'm here.
Thank you, Glenda. Bethany Harvey. Jasmine Huila Flores. Dana Steringer. Sam Coe.
Here. Sorry, I had to unmute.
Thank you, Sam. Maggie Klein. Thank you, Maggie.
Super. Thank you very much, Spencer, and thank you again for all of those RAC members that are able to join today. Let's go to the next slide. I wanted to cover and share the Oregon Health Authority's vision and health equity definition, just to sort of ground us in this work. And really, as many of you may have joined one of the April listening sessions or community conversations that we had about care coordination, we talked about this vision for the Oregon Health Authority, which reads a healthy Oregon, where people and communities achieve optimum physical, mental, and social well-being. So thinking about really whole person care, whole person wellness. The Oregon Health Authority has adopted a health equity definition that I do want to read, again, to ground us in this work. And that is, Oregon will have established a health system that creates health equity when all people can reach their full health potential and well-being, and are not disadvantaged by their race, ethnicity, language, disability, age, gender, gender identity, sexual orientation, social class, intersections among these communities or identities, or other social determined circumstances. Achieving health equity requires the ongoing collaboration of all regions and sectors of the state, including tribal governments, to address the equitable distribution or redistribution of resources and power, and recognizing, reconciling, and rectifying historical and contemporary injustices. I know that's a mouthful, that's a lot to take in, but just know that we are committed to really working towards eliminating health inequities in Oregon by 2030. And we need to change the way we've done things at Oregon Health Authority, and in particular, how we have partnered with communities in the rulemaking process to help guide how we build programs and set policies. So again, thank you for your partnership with this. Okay, next slide. Again, care coordination really is important, because we know that for anyone to receive that whole person care, there needs to be coordination between the care providers, your doctors or your care team, and that we have better health outcomes. We achieve better health when the care that we receive is coordinated. Let's go to the next slide. Okay. So I've covered a lot of information and I've taken up about 20 minutes. So just take a moment to breathe wherever you are. The pictures here are just a couple, you know, whether you're in a city setting, whether you're indoors, maybe you're in a park, maybe you're at the beach or in the mountains. But take a moment so that then we can now dig into really these rules. Okay, next slide. We have not had general rules for care coordination in this Division 120 section. And so really we are building this from the ground up. And I won't read all of this, but I just wanted to describe what are some guiding principles as we develop these rules. And really, again, it is to assure that the same level of care coordination is happening for the Oregon Health Plan members who are served through an open card or fee-for-service delivery model, that are members who are enrolled into a coordinated care organization or CCO. About 90% of people on the Oregon Health Plan are enrolled with a CCO, which leaves about 10% of the population covered through this open card system. So it's really important that we have the same high level of care coordination expectations. We're learning what has been working well from our tribal partners and their successes with care coordination. We took the information from the April listening sessions about care coordination to learn what is important to people and communities, and incorporated that into the draft rules. And again, the goal is that people in Oregon with Oregon Health Plan are getting the right care at the right time, in the right place or space, and that information is shared among the right people. So all of the care team and the patient or the patients or members' families. Okay, next slide. Now I will transition to taking a look at more detail about the rules and the Rules Advisory Committee participant fact sheets. So I've linked those here on the slides, and you were emailed these as well for everyone who registered to attend these sessions. So I invite you to take a look at those. I will just say that on the participant fact sheet, and Edgar, if you want to click on the link for that, for the English version, there's also a Spanish language version. Maybe the link works, hopefully. Okay, thank you. Really, I wanted to emphasize that the RAC's role is really to advise Oregon Health Authority on these draft rules. Consensus is not necessary, but we again invite all comments and inputs from RAC members. As you scroll down on the page, you will see, thank you for zooming that. You will see that there are a number, keep going. There are a number of next steps. Again, if we are not able to get through all of the rule draft today, there will be additional opportunities. Starting with, RAC members will be invited to submit email comments and input. Send those to me before 5 p.m. on July 5th. So about a week and a half. And then some target dates for future activities, including a public comment period and a public hearing. So let's switch back to the slide now. Thank you. And let's open up the first of the three rules, which is, there's a link there, 410, 120, 1215. Okay. Yes. And as you write questions in the chat, appreciate those. If we're not able to answer those directly, we will be capturing those and incorporating those into our internal review. Is there a comparable board or that votes on drafts of OARs? Really, Sam, thank you for that question. There is not a board per se, but there is, as we move into the process of reviewing the rules we did some internal review before bringing it to this Rules Advisory Committee meeting. After these meetings, there'll be further edits and changes to the draft rules. Then those, and again, with some internal review as well as inputs from other agencies that we work closely with. And then it goes back out to, or gets reviewed by Oregon Health Authority leadership. That's really the sort of approval before the rules are finalized. But even before finalized rules, there's that notice of proposed rulemaking, and then a time period for public comment and a public hearing. And then final edits to the rule that are approved internally by OHA leadership. So that's our process. Thank you. I know that these rules are, there's 3 different rules and there are multiple pages. And I thought it might be easiest just to look at, for this first rule is to look at page 1 of the rule, which is sections, I think 1 through 5. And this really describes the framework or the systems that need to be in place to support care coordination. There's information about making sure that care coordination is considers the needs of the individual. So really thinking about what a specific individual might need. It has information about collaboration between state agencies such as the Oregon Department of Human Services, ODHS, and the Oregon Department of Education, ODE. There's coordination with Medicare for individuals that are covered by both Medicare and Medicaid. So I want to pause and offer or invite any of the RAC members to raise their hand, come off mute, offer questions or comments about page 1 of this first rule. Don't be shy.
Hi, I guess I will chime in. My name's Kim Tice. I'm with the Oregon Center for Children and Youth with Special Healthcare Needs. And I just had a question. I appreciate the list of organizations in number 3 there. And just had a question. What about the folks that have fee-for-service as their secondary insurance and have private primary insurance? How is that coordination expected to happen, or what is expected of OHP in that case?
Thank you, Kim. Great question. I'm not sure I have an answer off the top of my head. But I will, I guess, offer that for our fee-for-service population, whether they have other insurance or not, we currently utilize a contracted organization that manages the care coordination piece. And I would think that the expectation would be that there would be some opportunity for communication and collaboration between that contracted entity and the primary insurance coverage. But I would think that for individuals who have third-party or private insurance, that organization would take the lead. So, Kim, I guess as you think about that scenario, and you may want to take some time and email me if you have a specific language that you think we should incorporate into this section 3 to clarify that. Good call out.
Yeah, thank you. I appreciate that. It does seem like that would probably need to be clarified, just so folks are aware.
Okay, thank you. Okay, Sam, go ahead.
Hi, for number 3, for like Oregon Department of Education is listed there. But unlike our sister state agencies, we're not a direct service provider. A lot our students get our services from their school districts or an education service district. So because we don't educate, I was wondering if like school districts and education service districts could be listed. The only direct service that we have is Oregon School for the Deaf, and that is when school district places kids at Oregon School for the Deaf.
Okay, yeah, thank you, Sam. Again, if there's some specific way to incorporate that language to add clarity, welcome that. I do also know that, within chapter 410, there are program-specific rules that are specific to the school-based health services or school-based services, and that might be detailed. So we may be some cross-reference between this rule and those rules. Thank you for bringing that up. And I saw Maggie had a comment about section 5, seemingly overly broad.
Overly broad, specific to the phrase oversee any relevant coordinating entities. And then I just noted it's one thing to oversee the care coordination for an individual, but to oversee an entity, I think, has different implications. And I don't think that's what was intended there. So it was just an observation reading through the rule.
Okay, super. Thank you, Maggie. Yes, I would agree with that. We'll see if we can rephrase that. Okay. Let's move on to, I'm gonna move us along fairly quickly. So again, if there's something that you think of that we didn't have time to cover or that you think of later, RAC members, feel free to email those comments to me by July 5th, 5 p.m. On to page 2, which is sections. Well, let's look at sections 6 through 8, because section 9 is a really long section. So this section, these sections again describe how coordination between programs should happen, or what are the goals about care coordination. Again, focusing on what are the individual's needs to improve their health and manage any chronic conditions. Being person-centered, which means, including consideration of any accessibility needs, that is trauma-informed, culturally and linguistically responsive. And again, anyone who wants to come off mute. Okay. Sam. Thank you.
Sorry, I have a lot of questions because I'm new to this. So, for how about for students or adults that have low cognitive abilities? Like does the system have somebody that'll kind of like in education where like surrogate parents or whatever, or parents that can't really participate or make decisions, like or like do they like, well, individuals that have someone looking out for their best interest? I'm just wondering.
I can't speak to what individual members may or may not have in place, but I do believe the rules that we've drafted talk about coordinating with the individual, the individual's identified. I'm not not finding the right words, but whoever is the designated representative for the individual. So I don't know if that is what you might be thinking about. So it would really, again, be the care coordination entity, in other words, the contracted entity that identifies who is the primary person to connect with regarding an individual's care or care coordination needs. I'm also reading, Tammy offered a comment. Yeah. Okay. Let's see who's that. Who? Marilyn, if you're speaking, we can't hear you.
Thank you. My comment is related to Kim's earlier comment, but is referenced here in number 6 around the lead care coordination entity's responsibility to collaborate with other entities. Where is it addressed specifically when there is a change in primary insurance, how that will be communicated and operationalized among entities? That seems to be an important piece.
Thank you for that comment. We'll take a look at that. I know there were other comments, and again, in the chat, appreciate, again, we may not get to all of the comments. And but by having them in the chat and by having this recording, we will have a record of those and be able to come back to those. Okay, let's move on to section 9, which goes on for several, like a page and a half. Oh, okay. Thank you. Tammy had a question about, I'm reading it in the chat as part of CMHP Community Mental Health Program. We try to build a primary insurance, but they often simply opt not to pay. The insurance companies know we are not going to turn the individual away, so we really have no power to help them. I'm hoping the state would have more power. Thank you for that comment, Tammy. We'll take a look at that.
Got a question. How would an organization go about wanting to
Speak that.
How would an organization go about wanting to take part in fee for services?
Oh, okay. So the question was about needing to understand how an organization would participate as a fee-for-service provider. So that would likely be a provider enrollment piece. So again, visiting the Oregon Health Authority's provider and the OHP provider page on our website would be where I would start. Okay, I'm going to move us on to section 9. We're at 50 minutes into our session. So 9 is a very large structure section that really, again, talks about the infrastructure. In other words, what is the framework for building a system that supports the care coordination activities. And this section talks a lot about having either technology and processes, contractual agreements, or memorandums of understanding between entities to really do that collaboration. That's my summary of a very large section. So again, I'll open it up to the RAC members to offer questions or comments about any of section 9 or the subsections in this area.
Hi, this is Kim Tice with Ocean again, and a couple of comments. One is in 9A, there's sort of a list of times when we need to be monitoring different care coordination activities. And I'm wondering if that's a spot where we might call out when individuals are changing between CCO and fee-for-service as a time when we need to be monitoring that for care coordination. And then further down in Rule 9, in large letter H, it talks about the MOUs governing coordination with other entities described in Rule 3. And then it includes at a minimum aging and people with disabilities and the area agency on aging. And I'm wondering, so those are very adult specific organizations. I'm wondering if we should call out any organizations that serve children there as well, perhaps developmental disabilities, or if it just makes sense to leave out the specific agencies as they're all referenced in Rule 3 anyhow.
Good call out. Thank you. Yeah, it might be, it's sort of weighing that, listing everything that possibly might be there versus having it more broad and not calling out one or two, if I think I understood. Yes, Sam, good call out about being mindful about protected health information and compliance standards. I think for all providers, there are some general rules that speak to security requirements with their health records and any I guess agreements that they have. So I think that already is in Oregon administrative rules, and we may be able to reference where those are, but appreciate that call out. And Maggie's offering comments. I'm reading some of these comments so that if there's folks that are on the call today or in the meeting space today, but you're on your phone and you can't see the comments or the chats, or it'd be just too tiny. So Maggie offers a comment about requiring care coordination for every change between primary insurance to a new insurance would have administrative burden in the complex cases. The handoff is what's needed. Yeah, appreciate that, Maggie. Thank you. Benjamin offers a comment to regarding topics 8 and 9 about lowering barriers to care, improving infrastructure. So, thank you. Again, these RAC sessions are not intended to necessarily answer all your questions, but it's really an opportunity for the Oregon Health Authority to listen and take feedback and really hear from those of you that are affected by the rules and how we can make these more clear and reflective of what you need and what the Oregon Health Plan members need to support their care. Thank you. And Benjamin offers comments about the transition of care when individuals might be referred and receiving care in a distant facility and how that can create barriers. Kind of summarizing any way there can be more options. Thank you. Appreciate those real life examples that those of you working out in the field are doing and sharing with us today. Okay, I think I want to move us along. Offering another idea about that private insurance, secondary insurance. Appreciate that, Kimberly. We'll capture that. So let's take another breath before we transition over to the next rule. So feel free to stand up. Stretch your arms. Take a breath. Take a drink of water. Okay. Thank you, Edgar, for managing the slides and sharing your screen. Let's go ahead. The second rule in this three-part series is 120-1220, and this rule is focused on how individuals are identified who could benefit from coordinating care. So again, a brand new rule, so the entire rule language is drafted. And I think for this rule, if we look at page 1, that covers, one moment. Well, let's just look at sections 1 and 2, which is most of page 1 of the document that is being shared. And again, this rule really is written so that it helps identify those Oregon Health Plan individuals that would benefit from, at least to be offered assistance with coordinating their care. It talks about utilizing a screening tool. One tool that is term that is used for that is a health risk assessment, or a HRA abbreviated. And these are again brand new rules. So interested about the open card or fee for service population. Is this, are these reasonable? Is the time frame reasonable? So I'm seeing a number of comments. So thank you for those. If anyone wants to come off mute and have some conversation, welcome that from RAC members.
So this is Maggie from OHSU. I just noted that this section 1, where it says individuals' physical, developmental, behavioral, oral, and social needs, in the prior little section, it used the term dental. And I know from previous revisions, it's gone back and forth. I think we just want to be consistent. Is it dental or is it oral that's going to be used?
Thank you, Maggie. Yes, I know sometimes there's differences in approaches, and absolutely we want to be consistent. So we'll confirm what is the appropriate term. Okay, well, let's move on to section 3, which is at the bottom of page 1 and continues on through all of page 2 of this rule. Again, so section 3 is describing information, again, of various sources of information about an individual to determine what is needed to understand what those individual needs are for an individual. And care coordination entities often will look to a variety of sources, such as claim data or identifying if there are new medical diagnoses or emergent needs for an individual, where that could trigger a care coordination entity to reach out to an individual or that individual's designated representative to offer care coordination. Thank you, Maggie, for the comment regarding how frequently and in what ways does a care coordination entity reach members? And we are looking to, again, we want to make sure that all Oregon Health Plan members are receiving the same high quality level of healthcare services and coordination of those services. So regardless of whether a member is receiving services through the CCO model of health delivery or the fee-for-service model, that they're equal. Those are, there's not a disparity between those delivery models. So we do want to align as much as possible. The rules in Division 120 as the corresponding rules in Division 141, which are specific to the CCOs. Thank you for the question. Sam will take a look at that about Albertina Kerr and Wynn Watts.
Right, for that setting, it's not a hospital, you know, it's a subacute, so and then I was looking at the list, A through S, and I don't know like where that would fit under.
Okay.
Perhaps, yeah, under residential, like letter A. But then their length
Okay.
of stay is so short, that's the thing.
Sure. So it might be a post-acute hospital, but it's not a long-term care or skilled nursing facility, it sounds like. It's a subacute. Okay. Okay, let's go on to sections 4 through 6, which are on the 3rd page of this rule. And these 3 sections again talk about mechanisms to coordinate and across different systems or programs. So we know that there are individuals that might be enrolled with a for services that are for special health care needs. Often there might be those youth with special health care needs, as well as other Medicaid funded long-term services and supports. I see some comments. Can invite any comments from RAC members if there are pieces in sections 4 through 6 that need to be clarified or added to. Okay. How's everybody doing? Still with me? Again, we'll have more opportunity to offer input. Again, RAC members can continue to review these draft rules. Send me email, comments and questions by 5th, 5 p.m. And then also for anyone, either in this virtual space and the general public, there will be a public comment period after we file a notice of proposed rules. So again, there's more opportunity to provide input. So let's go to back to the slide and with the list of the rules, and we will take another breath and look at the third rule. So thank you, Edgar, for pulling that up. I'm going to take a drink of water. Alrighty, this is a long rule. It's 5 pages. So this rule again borrows from the Division 141 rule, and this specifically looks at for the fee-for-service or open card population, and we'll often use those terms interchangeably. But again, aligning with the care coordination and service coordination expectations that are in place for the CCO. This rule, again, goes into details about how it is that care coordination entities really coordinate services for an individual across organizations and care settings. So let's take a look at on page 1, sections 1 through 4. Section 4 continues just a little bit onto page 2. But welcome any RAC member comments about sections 1 through 4. Okay, Marilyn, what you have first? Okay, appreciate that, Marilyn, about section 3, looking about some language specifying what's required for communicating when there's a transition of care, so, or a transition of coverage. I believe, Marilyn, you might be talking about transitions between, say, a CCO enrollment and fee-for-service enrollment. Yes, thank you. That is often, I hear that is often a challenging point, because as individuals may move geographically, or they may disenroll or become unqualified, or are no longer qualified for Oregon Health Plan, but then requalify. And that, what we call churn, or that turnover, is often a difficult time to lose track of what an individual might need. And any other inputs about sections 1 through 4 of this rule? Okay, well, let's move to page 2. Section 5 is a long section. It's all of page 5 and most of page 6. Section 5 speaks to how care coordination entities must ensure that services are actively coordinated for individuals when it's requested by the individual, their representative or guardian, and an involved provider or entity when an individual's needs are identified. And it goes on to say in a little more detail in section 5 that there are different mechanisms for identifying when an individual's complexity of care changes, or the needs are more complex, and therefore a higher level of care coordination is needed. So in other words, the more complex an individual's care is, then a more intensive effort around coordinating that care would be appropriate. Sort of scaling to, again, the needs of the individual. Again, certainly open card members, regardless of their complexity of their situation, can all have access to care coordination, and they can opt out of that care coordination support. So it's really member focused, member driven. Sam, go ahead.
So, when those open care plan are reviewed or reviewed annually, are like the parent or the individuals a participant, or is it reviewed by like professionals? Like,
I believe in the rule there's a place, I may not find it. I'm looking at page 2 in section 4. D, big D. Oh, I'm sorry, I'm looking in section 5. my apologies. Section 5, big D, it reads, in consultation with a clinician that has the appropriate qualifications and clinical practice history to review and revise the care plan, considering the OHP individual's complex physical, developmental, behavioral, or dental health care needs.
Okay. And then, so like in section C, like, small letter D, it says open care plans, and in other sections, it says care plan. Is there a distinction between care plan and open care plan?
Probably not, probably just, we need to be consistent in language. Thank you.
Okay, yeah, that was my thought, like, ooh, because I saw care plan, then when I saw a small letter D, under section 5, he said, oh, open care plans must be reviewed. So I was thinking it's a different type of plan. Okay. Just wondering.
Well, and I believe, there are times when a care plan is closed. In other words, whatever a particular need has resolved, and therefore that care plan could be closed. So, but we'll look at that language. Thank you, Sam. Thank you. Comments from inputs from Jennifer, Valentine, Bonnie. Yes. Thank you. Okay, we're doing really well, folks. Thank you. Let's move on to section 6, which is at the bottom of page 3. And I'm sorry. Yeah, bottom of page 3. And then continues on to the following page. Again, this section starts to talk about the care coordination for individuals, regardless of where an individual is receiving services. So thinking about those times when there is a transition in settings, in care settings. So as was mentioned earlier, thinking about what is needed for an individual when they are in a residential setting versus a subacute setting versus a community-based setting, independent living setting. Those would be different care settings. And regardless of where an individual is located, they may have needs for supporting coordination of care. So any comments, questions, or suggestions about section 6? Thank you, Kimberly. Excuse me about the transitions again between CCO and fee-for-service coverage, the warm handoff, I believe, Sam, but I will confirm that the 20-day benefit is calendar days.
Thank you. And how about, for the 2-day notice for discharge on capital letter C, it says 2 full days. I wonder if those are calendar days too. Cause it'd be rough, to get notified on Friday and then, Saturday, Sunday, and then they're gone. Sorry, I'm wondering like how, like for capital letter C, it says no less than 2 full days prior to discharge.
Yeah. Excuse me. Yes, I believe that would be calendar days, but I will confirm and recognize that, yes, Friday discharges pose challenges. I experienced that myself with my family. Okay. Well, let's move to section 7, which is on the next page. This references again the needs for those individuals who also have long-term services and supports or special health care needs, and how those needs would play into what the coordination of care might mean for transitions between levels of care or settings of care. It speaks to involving the individual, their representative, guardian. So any RAC member comments about section 7? Okay, Marilyn, I see you've added an edit. Thank you. To not only identify coordination gaps, but address or having the strategies to address those gaps. Good call out. Okay, we've made it to the end of that third rule. Thank you. And Maggie, appreciate that comment regarding section 7 little a, and the potential burdens. And yes, we can certainly consider taking a look at that. Thank you. And this is exactly, you know, the feedback that we need to hear of what creates barriers for not only members, but providers and partners that work to serve and support Oregon Health Plan members. So thank you for those call outs. Let's go back to the slide deck. Again, invite you to stand up, take a stretch, take a breath. We've been at this for an hour and a half. Appreciate you, again, sticking with this work. And let's go to the next slide. I put this slide back in, repeat again, just to center us as we think about our vision and our mission and the Oregon Health Authority's health equity definition. Because we want to strive to have administrative rules that really reflect our vision of eliminating health inequities in Oregon by 2030. And we want our programs and policies to support our work to create a health system that achieves health equity for all people so that they can reach their full potential and well-being. So I just wanted to revisit that, and we'll go to the next slide. And talk about some of the next steps. We've got today's Rules Advisory Committee meeting. We have another repeat, different attendees, but same content meeting for tomorrow. Again, there's my email to invite RAC members to submit additional comments, questions, specific language edits for us to consider. Send those to me by 5 p.m. on July 5th. The goal is that we will have some additional edits for these rules based upon your RAC input. We'll do that during the month of July. A goal of having a notice of proposed rules filed by the end of July. And then in August would be a public comment period, again, for anyone proposed rules, plus a public hearing. In September, after we take in all of that public comment and input, there'll be, again, additional review internally and with our key partners, and approval by leadership, usually also consultation with the Department of Justice, and then filing permanent rules towards the end of September for an effective date. Those are probably aggressive timelines, but appreciate you know, your inputs and it may be later than that, depending on how much input we get during that public comment period and internal review. All right, let's go to the next slide. There's just a couple more pieces. I do want to thank you all for your partnership and guidance. And before we sign off, I wanted to, I didn't see this slide come up, but I wanted to ask about, as you think about the health equity definition, I would ask if, as you think about these draft rules, do these rules impact that racial equity, health equity goal? In other words, are there any individuals or ethnic or racial groups that are impacted or that would be impacted disproportionately about with these rules? Again, anyone, if you please offer comments in the chat or come off mute or raise your hand. Okay, and then the other piece that we want to inquire about is, are there any fiscal or financial impacts to these draft rules? Are there, would these rules create any costs incurred, expenses, or any potential cost savings for providers, for partners, for community? Thank you, Marilyn, for pointing out about where the member is present and participating is an equity strategy. Yeah. We often, I guess, what I often find challenging is being able to reach OHP members to participate in these kinds of rules advisory committee meetings, and as well as considering about equity. So appreciate that. And Maggie points out the challenge of accessing the health-related services flex funds for fee-for-service, which is one mechanism that's available to CCOs. Yeah, I know there's conversations. There have been conversations about that. Okay, well, if there's not any other comments or questions from the group, those of you who have stuck around to the end, thank you again. I have much gratitude for your participation. As you can see in the picture, it really is a village. It takes a lot of people coming together and working to make sure that our Oregon Health Plan members are receiving the services that they need to manage their health or improve their overall health. So I will stay on for a few minutes if anyone is more comfortable just speaking in a much smaller group. I'm happy to stay on and have conversation. Otherwise, I hope you have a wonderful rest of your day. And I will be sending out the slides as well as a short survey to get your feedback about how you experienced this RAC meeting. So take care, everyone. Probably stop recording.